Thank you. And I'd also like to thank the organizers, especially you, for inviting me to be here. This is my first time in Turkey. I'm not going to have enough time to quite go around and sightsee as much as I'd like to, but hopefully I'll be able to do a little sightseeing. Well, I get some great topics to be able to talk about today, and one of the first ones that I think is a fun thing to think about is starting up a molecular laboratory. But first I want to see from the audience how many people already have a molecular pathology laboratory. So about, I'm going to say a third. How many people do not have a molecular pathology laboratory? Okay, so about another third. And the other third, do you work in pathology? Who are you? Oh, they're residents. They don't know where it is yet. They haven't figured that out yet, but they'll be there. Well, so about a third of you probably are going to sit here today and think, maybe this is somewhere I need to be. And I think Professor Dietl told you very well that this is somewhere you need to be. And it's really not even a question anymore about why one would want to or need to start a molecular pathology laboratory. There are many questions, though, about how we go from point A to point B, which is actually starting a molecular pathology laboratory. And these questions are very broad, and we'll talk about a few of the issues in starting a molecular path lab today. One of the things that you might want to think about, though, are the reasons why not to start a molecular laboratory, and then we'll start thinking about the reasons why you should start a molecular laboratory. Now, for those of you who already have a lab, these are still fresh issues. Even when you already have your lab and it's going and running, you may frequently be asked to defend your lab. And so I think even those who have a laboratory already have to constantly be aware and thinking about why we do this, what we do today, because these tests are costly. They add cost to the healthcare system. They add cost to testing of patients. They add cost to the care of a patient with cancer. Now, I'm going to argue, most of you would argue, the cost is minimal compared to the gain. And we do make those arguments all the time. The case examples you just heard about are examples of cancers that are treated with very, very expensive drugs, extremely expensive drugs. Compare that 30,000 euros or the 10,000 US dollars a month for the targeted therapy to the $600 test, and you can see the cost benefit is in our favor to do the testing. Still, we have to defend ourselves, and we have to defend the cost that it adds to do a molecular test to an otherwise histologically definable cancer. It's time consuming. Those of you who run laboratories already know that we get complaints every single day from clinicians who say, why are my molecular results not ready? Now, this has two sides to the coin, because although it is time consuming in the care of a patient, it's more time consuming not to have the laboratory. It's more time consuming to have to send it to a centralized laboratory and wait for the result to become incorporated back. Another question that we always face when deciding whether to start a molecular lab is, do I have the technical expertise to be able to do this? And we'll talk a bit about what you need in order to be able to start these labs. Oh, space. I'm sure you people don't have space issues in Europe, right? You don't have space issues in Turkey. No, there's unlimited space for hospitals. So I fight this battle every single day for space, and I'm sure most of you fight it too. Now, molecular labs don't require a huge amount of space, but the machines are big and they take up space and the labs take up space. So we do end up fighting for space on a regular basis. At my institution, I am not fighting for space anymore. I am now fighting for power. And I don't mean control and authority. I fight for that too. What I mean is the kind that you plug into the wall. I do not have enough electrical power to plug in the next generation sequencer. I know it's ridiculous. You can't believe it, but it's true, because they take a lot of power, and our old buildings are not set up to have 12 things that take a lot of electricity plugged into our old walls, and this is another issue as well. You've heard a little introduction about the specimens that we deal with, and you'll hear a lot more today about the specimens we deal with. I love tissue. I love slides. I love my H&E. I love my formalin. I'm an anatomic pathologist, and I like making diagnoses. But they're not the most optimal specimens you could ever deal with. So we have to think when we start a laboratory about accommodating for poor starting material. Poor is a relative term. It could be worse. It could sit out from Friday to Monday and not be fixed. But once we fix it, we know we also have issues with that. The other issue I think we overlook and don't think about enough is that the volume of testing can be very low for some of these. If you think about the ALK translocation in lung cancer, it's a critical test and a critical thing to know about, and it's only present in maybe 2 to 4% of lung cancers overall. Now, should we not do it because of that? Absolutely not. It's a critical test, but you have to realize that you're going to be doing low volume testing, which means that you will have expertise issues and you will have cost issues because the cost goes up as the volume goes down. Can we avoid it? Absolutely not. Molecular pathology is the future of anatomic pathology. It's not even the future. It's the present of anatomic pathology. This is here. It's changing the way we practice healthcare, and it's changing the way we practice anatomic pathology. But I'd like to reiterate that there is no substitute for the pathologist in this. Absolutely no substitute. There is no substitute for somebody with morphologically trained eyes to do molecular testing and interpret molecular testing in the context of the disease and the clinical picture. So I completely support that. What's the diagnosis? How many residents are in the room? Where are the residents? Raise your hands. I'll find you. Okay. Diagnosis? Lymphoma? Others? Small blue cell tumor, that's the correct diagnosis. Absolutely correct. What's the diagnosis now? With a Ewing's translocation? Ewing's, right? So you can see immediately that you can take diagnoses that have a broad differential and narrow them down to a specific diagnosis when we have molecular tests incorporated into that. That's not the whole picture. Many more components go into that differential. But the power of molecular is incredible when you start talking about adding it to what we do today in morphologic pathology. So molecular testing, here to stay, something all of you will think about in your future and in your present. Now, when you start thinking about a molecular pathology laboratory and starting one, though, there are some real hurdles and barriers to actually just building this lab and making it happen. One of the first questions I always urge people who are thinking about a new lab to think about is, what's the purpose of your lab? And the other question is, what kind of testing do you think you'll be doing? These two questions will definitely direct you directionally about what kind of lab you'll build or what kind of lab you'll start. What do I mean by this? The first question, what is the purpose of your lab? What is your mission? What are you trying to accomplish with your molecular pathology laboratory? Who will run your lab? Who's going to do this? Is it going to be you, somebody else in your department? Who's going to staff it? All of these are practical but real questions you'll have to face. And lastly, what kind of assays will you do? And this actually becomes important as we start to thinking about the direction that oncology testing is going and what kind of testing you would like to be doing in your own laboratory. I think of mission in several different ways. Now, in the United States, this is skewed in one direction or has been skewed, and I'm not sure that's as true in socialized medicine. And because in the United States, many laboratories start this process for money, revenue. They think of this as something that can generate money for the pathology department. And I usually just put a big red X through that and say, good luck with that. Good luck making money in molecular pathology. And the reason why is because molecular testing is expensive. When you talk about small volumes and you talk about the expertise you need and the reagents you need, it doesn't break even. In fact, it usually loses money. So if you're thinking about it from a revenue perspective, it's not a very good argument. Now, those of you who run labs already know that you make this argument every day. Why are you losing so much money? Because I'm supposed to lose so much money. The reason why that happens is because of the way that the molecular testing is incorporated into the diagnostic algorithm. More importantly, for most laboratories, most are not doing this to make money. For most of them, they're looking at running a laboratory for patient care because I need to provide best practice. I need to provide standard of care diagnosis in my hospital for my patients. In the middle there is this concept of being competitive, and this really is usually regionally or locally, where you want to be the one laboratory that has all of the testing for patients that will then come there. And this happens more so in the private sector than in an academic institution where the competition is usually directed at a different level. These scenarios will drive how you design your laboratory. If you're looking to be competitive, you will be different in your format and the way you put your lab together than if you just want to provide standard of care best practice for your patients in your hospital. Very different scenarios. The second question about what you already have and who you have, who is able to run this laboratory is a very important one as well. Many of you in this room are probably thinking that this will be you, and that's great because you're here. You're going to learn a lot over the next couple of days and probably be well situated to be able to go home and think about this and do this. Lots of places come at this with nobody who has molecular expertise in their ranks. And they say, okay, who's going to be it? You raise your hand if you want to be it, if you want to be the molecular pathologist. Now, this is not a huge stretch because if you think about pathology in general, pathologists are very well situated to become molecular pathologists without a fancy fellowship, without years of a postdoc. Many pathologists have had training in scientific areas that are very applicable right to molecular pathology. Many pathologists are very comfortable incorporating and learning new technology. Most of you in this room have learned new things over the last year that your predecessors would have never known before. Some people in this room trained in an era where you didn't know about immunohistochemistry and incorporated that into your practice when it became new and interesting and unique. And that was new, that was different, and became part of pathology just like it is today. So you may have non-molecular people in your ranks who can do this very well. It is much easier to come at this if you have people who have molecular expertise or who have deep molecular interests. It's clearly going to be an easier battle and an easier road to go down starting a molecular lab with that expertise in hand. You're here, so you're going home with that, and I think that that is a wonderful place to start. The last question to ask is, what kind of tests will I do? And this is a broad spectrum as well. I think it's a much different scenario to say that you're going to start a laboratory that's going to do mostly testing based on commercial kits. You can buy many of these things. You can buy many of the tests, the assays are ready, you validate internally, and move forward with a commercial kit. It's much different than the scenario of wanting to be a laboratory that will do esoteric, unusual, rare diagnoses, where you'll develop the assay from scratch in your own laboratory, or somewhere in the middle here, where you go to the literature and find an assay and reproduce it in your laboratory that's already been done elsewhere. So these different scenarios will require different people in the laboratory to be able to go along with them. And it almost relates directly back to the previous slide. It's much easier to take a non-molecular pathologist, someone who has no expertise in molecular, and use standard kits. That's going to be pretty simple. It's going to be very hard to take that person who knows nothing about molecular and say, go ahead, design esoteric tests from knowing nothing about this. They're only laughing up here because they've been asked to do this, right? What? You want me to do what? So you need to have the right people if you want to come at these in different ways. Most laboratories today have some combination of these three, but they're skewed in one direction or another. Most of the people who have molecular labs that are broad and do a lot of testing probably focus someplace in the middle here, where you're doing a lot of lab-developed tests, maybe a few kits, maybe a few esoterics, but are really largely in that middle zone. You got to think before you start your lab about who you have and what kind of personnel you'll need, what kind of space you'll need, and what kind of resources. By resources, I generally mean capital equipment. That's the big expense for most molecular laboratories. The consumables and the reagents are expensive too, but the capital equipment is where most of us get hung up with our lab administrators and our hospital administrators. So who do you need in an average molecular pathology? In the United States, there are guidelines about this, and I bet in Europe there are guidelines about this that are very similar, but it doesn't really matter because functionally, even if there weren't guidelines, you'd kind of need these people in place. The first is the medical director, the MD, PhD, or the PhD, depending on where you are in the world, who runs the laboratory. That's the person with the most expertise in the field. Oftentimes, if it's an anatomic pathology focused laboratory, then you are talking about a molecular pathologist who is an MD, who is a pathologist, who can look at slides as well. And this is certainly the person who will direct and guide the testing and the incorporation of the information. I've always found it easiest to work in a laboratory where I also have a technical director who's got a lot of expertise and who can actually assume the role of the medical director minus the medical part. And that is the person who you can say, here's a test, I need you to design the assay, I'll look it over. Because most of us in pathology have many different roles, and you're balancing those roles, not just one role. So this person is crucial to the laboratory. It's somebody who has at least a master's degree, preferably a PhD, who has deep understanding of molecular diagnosis. They may not have as deep of an understanding of pathology and anatomic pathology, and that's usually okay because that's coming from the medical director as well. Technologists and technicians, this is an interesting dilemma. I'm assuming that you do not have an abundance of technologists who are trained in molecular pathology, as we don't. Is that right? You're searching, you're hunting for these unique people. You're desperate for them. This is my scenario anyway. Okay, I live in Arkansas. It might be different if I lived in Boston or New York. Actually, it's not different. In the big cities, it's worse because those wonderfully trained people go to biotech companies and make lots more money than we could ever pay them. So this is a real issue for all of us, technologists and technicians. So many of us think hard about who we want to hire into these roles and how we're going to invest in them. It takes a long time to train these people. There's two options, generally speaking. There are the people who have formal training in medical technology, and they come at it from almost a degree in medical technology. And then there's the other end of the spectrum who are people who have degrees in science and work in research labs. And these are two different ends of the spectrum, and we'll talk about some of that issue as well. Now, don't forget, the last one's so important. We always forget. We get the text, we have the people doing the test. Don't forget, you're going to need secretarial support, administrative support, all of the behind-the-scenes work that really takes a lot of time and is very consuming. When you think about your text, I mentioned these two different options. I mean, I think that there are a spectrum between these two. But if you think about it, you have people who are research techs, who are in research labs, who do the technology. And they tend to know a lot about the technical end of the spectrum. They tend to be really good at technical work. I mean, they know the platforms, they know the assays, they know how to make them work. On the other hand, you have the clinically trained laboratory technologists. And they tend to be very expert in the clinical end of the spectrum. They understand validation really deeply, which on the research end of the spectrum is not such an issue. It's not the same kind of issue. And so what you really need to think about is how to balance this expertise. You need the people who have all this technical expertise, but you also need that clinical side as well. So I've always looked for a balance of people, not necessarily a balance of skills in one person. I like to have some of each. I like to have some really creative research type techs to do the early development, the very early pre-clinical test work. And then I like the clinical people who just plug away at getting the clinical specimens done with extraordinary competence and making sure that everything aligns exactly. I like both of them, to be honest. You have to train all of these people, and this is not simple. It is not simple to take a group of people and say, you are molecular technologists, now run the laboratory. There are, again, guidelines for how you train people, and I set internally those guidelines and make it very clear to the people that I hire that these are the steps you're going to go through. For any technologist or any technician coming in, you want to make sure that they go through a series of graduated steps to be able to learn the processing and the sample preparation and the testing. First, of course, observation. And this is sort of a fundamental way that we teach in medical school, in medicine in general, the see one, do one, teach one phenomenon, which we all are familiar with. So they got to watch. They have to watch first and have the opportunity to observe the technique. And then they're usually going to perform the technique under observation. So they watch, and then somebody watches them. All of this needs to be documented and formal. It cannot be informal. It cannot be thrown together at the last minute. You actually have to have a plan for training your technologists before they show up, before you hire them. The next would be to perform the technique in parallel with somebody else and see if the answers match up and the results are the same. And then lastly, we let them go on to independent activity after they've fulfilled these steps and have proven that they have the clinical competence to do this reliably. Not only do you have to plan this and make it happen, but you have to document each step in this procedure in order to have the right validation and documentation in your laboratory. Now, I also want to spend a minute or two talking about space. In molecular pathology laboratories, we talk about the concept of a clean area and a dirty area. And this is really a critical area if you're doing PCR-based assays in instruments that are not self-contained. So if you're doing assays that are kits or based on platforms that are totally self-contained, it's still important, but it becomes less critical. In most of our laboratories where we have a variety of tests, we really need to maintain this concept of a clean and a dirty space. You're going to see PCR over and over again over this week, over these couple of days. But the fundamental concepts of PCR is amplification. You start with a little, and you go through a procedure that ends up with a lot. Now, when you end up with a lot, you have to recognize, and it's not just a lot of random DNA, it's a lot of a very specific target. You have a serious potential for contaminating your laboratory in the space that you work in. And so what you want to make sure is that you do things to minimize the potential for contamination. The potential for contamination can be minimized from very simple things like the techniques you'll teach your technicians. For example, the fundamental technique of opening a tube. Now, simple, I know, but believe it or not, most of the people that come into your laboratory will not recognize how important it is to wiggle the top off very carefully and very slowly, rather than what we call pop topping, or top popping, right? Pop the top, and you have the risk of contamination. Simple thing, right? Simple thing. All the way to the more complex thing about where you place your laboratory and how you set it up. Now, where you place the laboratory, how you set it up, how people move between rooms becomes very crucial when you're talking about that potential for contamination. So the movement cycle from clean to dirty needs to be very specific, and the technologists need to be trained in this. So if they go into the microdissection room and then they move into the setup, which is the clean space, and then they move into the thermocycler area, and then they move into the dirty area, which is the post-PCR and the analysis area, you really want to teach them not to move backwards, because when they move backwards, they carry on them contaminants. I was in a laboratory where I read the procedure manuals, which had been written 10 years before, and they actually said that a technologist would take a shower before they entered back into the clean area. And I said, that is a really great idea. Do we have a shower? And they said, no, we don't have one. So make sure that you make it practical and realistic, because if you say you're going to take a shower and you don't have a shower, I mean, that's pretty impractical anyway. Certainly is the cleanest possible way. We had very clean technologists. But you need to teach this practice. It needs to be a practice that you never go back in, or that you're always going in one direction. And that space issue and the way you set up your laboratory is very important in protecting the testing that you're going to be doing. Now, this other question of resources is one I have no magical answers for you. Money is money, and it's money everywhere, and it's a problem no matter where you are. These machines are expensive. They require capital purchases. Your hospitals have to agree. The smaller instrumentation is not usually the issue. It's the large instruments that really cost a lot of money. And again, no answers for you there. Now, I want to just pick up a little bit on the first lecture in terms of the testing and how we're going to implement this in a given laboratory, because these raise issues for us. So you've heard about BRAF. You understand its significance. It's important in papillary carcinoma, melanoma, colon cancer, a variety of different tumor types. It's a simple assay. Sequencing is easy. It detects the mutation very, very clearly on sequence in general. But there are many options in test platforms that you can choose in order to do this test. There's traditional Sanger sequencing, pyro sequencing, allele-specific PCR, quantitative PCR. There are kits, commercial kits that you can purchase that you can put into your laboratory pretty easily. And very interestingly, there's even a new immunohistochemical stain for BRAF mutations. This is a great example of how a laboratory director, and when you start thinking about how you're going to set up a new lab, would have some really key decisions to make. You got to think about what you're going to be doing it for, how you're going to be doing it, and why. And just as the same example that's already been given, this is the drug that's the targeted therapy for melanoma and the BRAF mutation, which is now considered standard of care. You can't treat these melanomas with this drug without the test result. Thinking about resources, what equipment already exists, what do you need, and also an important factor we sometimes forget. What happens when my machine goes down? Is there a backup machine? Do I have a second one? Is there another one on my campus that I could use in an emergency situation? Remember that this is not fast. None of this will happen overnight. Setting up a lab, I said 2 to 4 months, and you're shaking your head. More like 6, more like 12. Depends on the space you have. It depends on what you have. It's going to take some time. Technical training, on average, in my experience, it's going to be 3 to 6 months before you will take a technician who's fresh with no molecular experience and have them be able to perform the molecular testing. Assay development, if you're doing lab developed tests, 3 to 12, maybe longer. You're talking about a pretty significant timeline. So you have to think ahead that you're going to be spending time setting up your space, training your technologists, assay development. You could be looking at 1 to 2 years before your laboratory starts even producing molecular tests. And these are challenges that we face in all of these areas. There are challenges that you're going to face on a day-to-day basis. This technical training, which we talked about, writing your procedures, troubleshooting your assays, validating new assays, and then finally, how are you going to integrate this back into the practice of pathology, and how are you going to get those results back in the hands of people who need them with a good interpretation that helps the clinician treat the patient. I only want to focus for a moment on this concept of validation. It's one that we sometimes forget and don't recognize how important it will be to us in the terms of bringing these molecular results back. There is a system that's been developed by the CDC in the United States called the ACE validation system, and this stands for thinking about in advance the analytical accuracy of the test, the clinical validity of the test, and the clinical utility of the test, and finally, ethical and social issues. These are very straightforward concepts, but we don't always think about them in this way, and I think it's good to start a laboratory and start thinking about them up front before you even start your lab. How well does your test detect this specific mutation, and what is the sensitivity of the assay? And the way we usually find this out is we perform our test on samples with known status. So we take a bunch of samples that we know the status of, and we reperform our test to detect the percentages that this can be done on. Cell lines, sample exchanges with other laboratories, or samples that we've tested by an alternate method are all totally valid. The clinical validity is very different, and that is how well does the mutation predict the disease. This is something that most often you won't be able to do very well in your laboratory. You'll have to rely on large samples and large databases that have already been done in order to do this. You can certainly do it on a small scale. I mean, you can use the assays on samples with known and with and without the disease, but it's usually too small to be predictive, and that's not something you're going to necessarily recreate. But before you begin, you do need to know the positive predictive value, the negative predictive value, and the false positive rate that you can expect with the disease and the mutation as you go forward with that. So just as an example that all of you will face when you start a molecular lab, you'll all ask this question, no matter who you are. If you're starting a molecular test, you're going to sit there and think, I wonder how many samples I need to test in order to get to the answer that I need. There's no magic. There's no magical answer. You can do a complex statistical analysis and still get no magical answer. Most of us are usually thinking about things like 30 to 50 samples if possible. But that's going to depend on the disease prevalence. Can you even get 30 positive samples, or 30 negative samples are easier to get? So a lot of this is going to depend on your access to the samples that you need and the expected positive rate before you can actually get at these numbers of how many samples you need to test. Clinical utility is really important, but it's something you can't answer alone. Clinical utility is something that you need to get with your clinicians, and you need to get together and decide, when am I going to do this test? What kind of samples am I going to require for the test? And how am I going to interpret the positive and negative in incorporating it into the patient's overall clinical scenario and their diagnosis? This is not something we do alone. This is something that groups do together. And whenever you're starting a new test, it's something that's important to think about with your whole population. The last one, ethical issues, I've never really figured out a way to address well. It's something to think about, and it's something to think about mostly in the world of payment and whether patients have access to the testing, but these are global problems, not laboratory-specific problems. When you're done with this, you're going to have a lot of documentation, and one of the most important documents that you as a medical director or a laboratory director will create is the validation summary that details the specifics of what we've just talked about in the validation process. Description of the disease and mutation, description of the validation procedure that you used, results from your validation studies, guidelines that you've developed at your institution to do the testing, and your signature, which is going to be one of your main and important goals as a laboratory director of this new molecular pathology lab. So although it's costly, it's time consuming, you certainly need technical expertise. It definitely takes space and electricity. You will definitely face challenges with specimens, and you will be worried about the volume of the testing until the day that you finish your laboratory. It still is our future, and it's still really critical to think about how we as pathologists can begin this molecular revolution and be a part of it. And with that, I'd be happy to turn it over to the next topic and speaker, and thank you very much.